Good morning. This is Dana Parsons with LeadingAge Virginia, and welcome to our Coronavirus Weekly Member Update Call. Thank you all so much for taking the time to be on this morning. We know how busy you are, so thank you for your participation today. We'd like to begin with Matthew Mary with the Virginia Hospital and Healthcare Association update.
Hey, Dana, can you hear me?
Yes.
Excellent. Thank you again for having us, VHHA, included in these weekly calls. And kind of the update within Virginia with regards to the hospitals, we've stayed pretty steady. As of this morning, current COVID hospitalizations is 1,566, with the current COVID ICU hospitalizations of 387 and ventilator use at 222, with total discharges of 2,042 with the hospital numbers. We did with the numbers with long-term care facilities. That report the data has improved over the last several weeks. We did have a little bit of an issue over the weekend with facilities changing names within our system, and we've corrected that. Unfortunately, our corporate entity may or may not have changed all their names within the system, which caused a glitch. As of this morning, we had 303 skilled nursing facilities reporting within VHAS. Of those 303, only 32 facilities did not report yesterday, which is an 89% response rate, which is exceptional. And I do want to give a big thank you to all the long-term care members out there with your reporting, as this data has definitely been crucial and will be quite useful as we move forward with the long-term care task force at the state level, led by Dr. Lori Filano. As of this morning, combined COVID-19 long-term care cases was 1,091. Confirmed cases were 788, with 303 pending. Do keep in mind that this information is only as good as entered by our members within the VHAS system. So we do encourage you to do this daily. One thing we are tracking heavier than we have in the past, as this pandemic is moving through the long-term care facilities, is the PPE. PPE shortages continue to be a huge issue throughout the Commonwealth, and we do encourage all long-term care facilities to continue to reach out to your healthcare coalitions, along with assisted living facilities would go through either DSS or your local health department. With the PPE reporting on VHAS, we do encourage you to go under the clinical operation status, and we've incorporated a drop down in there. If you have an insufficient needs of PPE, please select which PPE you're in need of. There's a big understanding that each facility has differences, as not only has face shield or N95 and surgical masks been an issue throughout the pandemic. Isolation gowns is quite the shortage, even worse, in my opinion, in some areas than the face protection. Not only long-term care, but some of our hospital folks, especially Northern Virginia and central regions, are experiencing these shortages. So we do thank you all for the reporting of this data. Our data analytics team has done a great job on assisting us with friendly numbers, and I feel the long-term care facilities have valued this data as we move forward, and we'll continue to strive to ensure that we're getting you all the information you all need. And please feel free to reach out to us at any time. Again, long-term care facilities, the point of contact, as always, is your regional healthcare coalitions within your region, and they're always here to help. Thank you, Dana.
Thank you, Matthew. It doesn't appear that we have any questions But thank you so much for that update. We appreciate it. So now lessons learned from the Department of Health. Over to you, Sarah Lineberger with the Department of Health. Thank you.
Sure, can you hear me?
Yes.
Okay, good morning, everybody. Today, reflected on our website in Virginia, we're up to 14,961 cases of COVID-19, and that includes 522 deaths. There have been 206 confirmed outbreaks, which includes 116 in long-term care facilities, which is 56% of all confirmed outbreaks. Again, a confirmed outbreak is 2 or more lab confirmed cases. I think good news is that we are working more and increasing capacity through the National Guard. They're helping with point prevalence survey screening, and we'll also be providing fit test training for long-term care facilities. Some local health departments have been doing that, but have limited capacity to do that. So we're working on information to share about how to coordinate with the National Guard if your facility is in need of doing fit testing for your staff. We've also, as the governor has mentioned, continued to look to the Medical Reserve Corps for staffing, and that has worked well in some long-term care facilities already. So staffing is definitely a big issue, and we hear you on that, and we're working on that through both of those avenues. I wanted to highlight a couple of key resources that have come out from CDC in the last week or so, some just yesterday. I'm going to put a link for that in the chat. They created videos on donning and doffing PPE, one for donning and one for doffing. I think they're really helpful. I think videos are always great for training staff, so I'd definitely encourage you to look at those. So hopefully the links work. I just put them in the chat. And then there are many webinars that they posted yesterday that are at the bottom of the long-term care page for CDC. And so definitely encourage you to check those out as well. One of the questions in the chat is, what is fit testing? So that is fitting staff members to wear N95 respirators. An N95 respirator has to be fitted to the person, and there are different sizes and brands of N95 masks. So it needs to be fitted to the person, and there are instructions on how to use those and wear those. So that's really a really important step if your staff are wearing N95 masks. Another question is, has anyone found a source for fit testing kit? You have some masks and know someone who knows how to do the fit testing, but you cannot find a kit. That's a really great question. I do not have a great answer, but I certainly can take that back. Matt, are you still on the phone? Do you know if the healthcare coalitions have fit testing kits?
Hey, Sarah, can you hear me?
Yes.
The healthcare coalition, so that's the issue, is it's the solution within these fit testing kits that has also become a shortage through 3M. I know the Near Southwest Preparedness Alliance in the Roanoke region hired a contractor out of North Carolina, I believe, to assist with this. I do know that some local health departments in the Commonwealth have it. It's not consistent. But do keep in mind that healthcare coalitions, some do, some don't. It's not consistent. But I do encourage the members on this call to reach out to your healthcare coalition, as well as they may be able to put you in contact with a resource, whether it's the local health department within your region, a contractor. And I do know the National Guard has attempted to assist with this, although again, it's been a supply issue of the actual supplies itself.
Yeah, everybody needs the same supplies all over the world, but I'll definitely take this back and see if we can create any more solutions on that. But thanks, Matt. I think it sounds like contacting your healthcare coalition and or like your local health department to start with would be good. I don't know if you've tried either or both of those, Peggy, but I will take that back as well. There's also a question in the chat about how many people in Virginia are considered recovered. I don't think we have that data. There's certainly a lot of interest around that and some work on that. You might be referring to the serologic testing, and we don't have that data yet. There's still a lot of work being done to look into the serologic tests that are being made available. Some of them are valid, some of them are not. So certainly caution using serologic tests just like directly from a company or off the shelf or something. Our state lab is looking into all those, and so more to come on that. And that's all I have right now, Dana.
Thank you so much. Really appreciate that. I just wanted to give another opportunity for some questions in the chat box. Okay. Hope you can stay on. Thank you so much for that update. We are going to be moving on to a topic about testing patients prior to hospital discharge and then transfer to a long-term care setting. We are thrilled to have Tracy Jennings, the Managing Director in Senior Care Services and Care Transitions with Centra. Tracy serves on the LeadingAge Virginia board and is also the chair of the Public Policy Committee. But before we move into Tracy, I see that we do have a couple more questions that have come in for Sarah. Melissa, would you like to go ahead and read those?
Sure. Sarah, do you see these questions? How many of those 14? I'm sorry, go ahead, Sarah.
Okay, so the question is, Madison County shows 14 cases, but some of those are weeks old. How many of those 14 are still considered active? I think that's a great question. There's a lot we don't know about the virus itself. We're seeing some folks who are tested weeks after their initial positive test who are still positive on PCR, and it's unknown if they're still infectious or if the test is just positive because there's still some of the viral material circulating, but they might not be infectious. So I think these are like really great questions, but the science just isn't there yet, and a lot of work being done to better understand like how coronavirus acts and how long someone's infectious. So I really don't have answers on that. I mean, as you know, for some of the CDC criteria for discontinuing transmission-based precautions, there are timeframes around that, with the thinking that, immunocompromised people might shed virus longer and be infectious to other people longer. We see that with other viral infections in immunocompromised people. But I would say we just don't know a lot about coronavirus. And so I think it's really hard to say when someone is recovered. And then I think the other question relates to your next topic.
Yeah, yes, it does. So I think, Ellen, we're going to let Tracy talk, and then Dana and I can give you an update on where we are with working with other groups to try and prioritize discharge testing of asymptomatic discharges to long-term care settings. So we'll let Tracy talk first, and before that, it looks like one more question came in for you, Sarah. Are there projections on the ramp up of simple things like PPE and testing availability? Is it just lack of national coordination? It seems like a simple supply demand question. Could you talk about that?
For testing availability is increasing in Virginia, which is great. We have a lot of university medical centers coming online and providing testing, and that's one of the reasons we've been able to increase point prevalence survey testing across the state. So in addition to our public health lab, we also have UVA and VCU supporting testing for facilities, and Virginia Tech will also be coming online. And the mini hospitals and private labs are also coming online to offer testing. I mean, certainly there is a supply-demand issue, because even with labs coming online, we still have some shortages of testing supplies, even like the swabs. So for some of the testing supplies, we're manufacturing more supplies in Virginia. For example, the viral transport media, our state public health lab is making that. But certainly, you know, with this impacting the entire world, there are supply-demand issues, and the labs continue to work through that. I don't know if Matt could speak to supply-demand issues for PPE. He might be better suited to answer that question.
Yeah, Sarah. So with regards to PPE, I know the Commonwealth, specifically VDEM, is securing PPE as we speak. Unfortunately, it's not the large enough orders as we would all hope, but I do know it's entering the Commonwealth at a slow and steady pace. With regards to that, though, we do need to know what the needs are within each region, and as mentioned, long-term care would get PPE through the healthcare coalitions. Assisted living would go through local health department /DSS. But we do need to have that documented for long-term care within the BHOS system, but you can also call the coalition directly and they can assist you with that as well. But when doing a request, be mindful, especially the facilities that are currently treating high levels of COVID-19 residents, that all orders may not be fulfilled as requested, especially the quantity. So we are trying to prioritize the impacted facilities to ensure their staff are staying safe during this response, but also doing our best to ensure that all facilities are able to get PPE to keep their staff and facilities safe as well. Thanks, Sarah.
Thanks, Matt. Thanks, Sarah. Tracy, we'll hand it over to you.
Hey, Melissa, this is Tracy. Can you hear me?
Sure can.
Okay, great. Hi, everyone. I'm Tracy Jennings. I'm with Centra, and Centra is a health system in the Lynchburg region, a health system with 4 hospitals and a pretty robust post-acute continuum and some outpatient practices. I have the opportunity to work in both the inpatient and the post-acute space. Have operational responsibility for case management for the 4 hospitals and oversee our senior care division, including our life plan community and 3 skilled care facilities. So an interesting perspective of looking at movement of patients throughout our system and throughout our community. About 3 weeks ago, our system took an evaluation and evaluated our capacity at our hospital, our testing capabilities, and really identified the biggest risk for our community was our long-term care and congregate living congregate living in our entire community. We at that time decided to move forward with some expanded testing opportunities. And so we have started on April 16th. We are testing all patients who are moving from our inpatient hospitals to any facility congregate living. We do a COVID test screen, and it's a test, but it's done for screening purposes, not for obviously symptoms or symptom identification. These are asymptomatic patients, and we're doing the test just for transfer. We try to do that test within 24 to 48 hours of the patient being transferred to any skilled care, long-term care, assisted living, independent living. And we're doing that for new admissions leaving in addition to readmissions going back to congregate living. The case manager will identify the patient, work with the physician, and get that patient screened and tested. I will tell you, overall, we have not had any patients that have popped up positive, although at one of our hospitals we have had 2 catches. So for the majority of all the discharges over those last 2 weeks, it's gone very smooth, but we did identify 2 that were on their way to a skilled care setting and being discharged, and we did that test, and those patients were asymptomatic and positive, and we were able to stop that admission and redetermine how we were going to move forward with that transfer. So I'm pleased to report that that process has had a positive result. In addition to that, when we admit into our skilled care facilities, we do, even with that negative test, we actually still isolate that patient for another 7 days, and then we test that patient again at day 7-ish, around day 7, and then before we remove precautions or before we move that patient out of a private room. Again, understanding that that virus is still potentially could be shedding or could be picked up on these asymptomatic patients. Those processes have been managed well throughout our system and received well throughout our hospital system, and very thankful that the hospital really made this a priority. And I'm happy to take any questions about that. Melissa, Dana, if there was more detail that you wanted, let me know. I see your question on the chat. The hospital system is Centra. It is in Lynchburg, Virginia, to Southside, Farmville Market, Bedford down towards Gretna. That's the region.
Thank you, Tracy. And so LeadingAge Virginia is working with a diverse stakeholder group, as well as, of course, the governor's task force is looking on this. We're having constant conversations to try and replicate what's happening with Centra all over the state. And so just know that we are continuing to dog this for our members, because we appreciate what Centra is doing. And thank you, Tracy, for sharing it. And we know that that is what providers need all over Virginia. So we are working on that. Dana, would you add anything else to that?
No, I think you've summed up that well. We continue to send that message, and we look forward to providing our members with updates as we can progress in this area of getting some consistency for a protocol.
And if you are having this experience with hospital systems in your area, if you could just put that in the chat box and let us know who else is doing what Centra is doing, that would be really helpful as we continue to have these conversations.
Thanks, Melissa.
And a question did come in of why isn't this the required protocol? Dana, do you want to field that based on the guidance?
Yes, so we have some guidance that's been issued that we've been working with stakeholders on for hospital transfer guidance. We need to get some consistency related to priority level of testing from hospitals. So that's something that we're continuing to work on. The guidance document that you all have does not say that that's required for that type of testing for transfers to a long-term care setting. But Tracy serves on our governor's long-term care task force, and we're continuing to work on that. So when we get some developments in that area, there may be some changes in the guidance.
And Tracy's actually presenting to the governor's task force this week. So there will be a broader audience that's hearing about this best practice coming out of Centra. So we hope that that will really start moving the needle on this.
Absolutely.
And to build on this, I think the question about why isn't this the required protocol around testing asymptomatic discharges to long-term care settings, the feedback we've gotten is it's a capacity issue in terms of how many tests are available. So as testing continues to ramp up, then we hope that this will become more of a priority. But just because of the limitations of tests, asymptomatic folks haven't been being tested. A question just came in for Tracy. Can you share information about the patients tested that were asymptomatic and were found positive? Did they develop symptoms in following days?
Those 2 patients did not. They were able to be transferred to a facility that was able to manage and isolate the patients appropriately, but they did not develop symptoms. They stayed asymptomatic. One of them was about a week ago. I understand that patient's fine. The other one is fairly recent, so more to come on that and how that plays out. I will say, Melissa, too, to kind of echo what you said, Centra's decision to do this was based on, our inpatient capacity at our hospital. We had the ability, we had the testing available, and so it maybe isn't right for every health system at this exact moment. I think, hopefully everybody wants to move in this direction, and the more we advocate for that, but it has to be right for all those reasons. What is being experienced in Fairfax is not what's happening in Lynchburg, Virginia. So, just very 2 different sets of circumstances.
Absolutely, Tracy. Thank you for that perspective. Dana, no other questions have come in, but if they do, I'll let you know.
Okay, thanks to you both, Tracy and Melissa. We're really pleased that we've been able to announce that the governor and the General Assembly have approved a $20 rate increase for nursing homes. Yesterday, we shared this information in our daily update along with the corresponding templates and things that were needed for nursing homes to complete in order to obtain this rate increase. I want to thank Thomas Gates, who's the Senior Advisor for Finance and Technology with the Department of Medical Assistant Services, for joining us today to provide an overview of this new development and answer any questions that our members may have moving forward with this process. So thank you for being with us, Thomas.
Great. You guys able to hear me?
Yes.
Wonderful. So glad to be able to join you. And as you're just saying, the governor signed HB 29 on Friday. And one of the provisions in that was this $20 per member increase in the per diem. So we've been working with your associations and with the MCOs on how to operationalize this. And the goal is really to make it as administratively not burdensome for you as possible, while still being able to turn around the process as quickly as we could. And so the way we settled on doing that is we will do this as a separate financial transaction rather than a change to the rates and claiming process. And so how it's going to work is we will be doing a monthly roster billing, and the roster should include all your residents who have Medicaid as the primary payer. And you can include days that you haven't yet billed for, but you should not include anyone with pending eligibility. And you'll provide those roster bills to both DMAS fee-for-service and separately to the MCOs. And we provided a separate template for DMAS and the MCOs to do that roster billing invoice. And then we will pay, and the MCOs will pay within 2 weeks, and that will be done as basically as a financial transaction, a one-off administrative payment. And the reason that's important is that is why the MCOs are separately asking you guys for banking information. This is running through a different process, a different set of systems for the MCOs, and so that's why they need you guys to kind of re-sign up your banking information, because it's just not running through their claim system. So if anybody wondered why we were asking you when we already have kind of financial relationships with all of you, That's the reason. It's really because we're going through this attempt to do a faster, kind of simpler process than changing the rates. The timeline is, as we've established it, is basically if you can get your March partial period, because this goes back, it's retroactive back to the beginning of the emergency period, it's March 12th. If you can get us the March roster by this week, both DMAS fee-for-service and the MCOs have committed to turning that around by May 15th. That assumes you got your billing information into the MCOs as well. And then the goal going forward is we will expect new rosters from you within the end of the first full week of the new month. So the end of next week would be when you would provide the April roster to us and to the MCOs, and we will make payments within 2 weeks of that. So that's the basic outline. We're going to do one reconciliation at the very end, and we have not fully detailed what that reconciliation process will look like. Both DMAS and the MCOs will do a reconciliation at the end of the emergency period, and we're going to be working with each other and with you guys on what that reconciliation will look like. But the goal was to not hold up the monthly transactions by trying to reconcile every month as we go, but to get the money out to you to support your operations and meet the goal of the Governor's Amendment and the General Assembly's action, and then we'll reconcile at the end of the process. So I think you should have 3 spreadsheets and a Word document that were sent out. The Word document is basically what I just told you. Walks through the process, kind of the high-level expectations, and then the 3 spreadsheets should be a billing information for the NCOs, and then a separate kind of roster billing template for both MCOs and DMAS fee-for-service. And the reason for the difference there is just we have to treat hospice days differently. And so for the DMAS fee-for-service side, we need you to tell us about your hospice partners enrollment. And on the MCO side, that's just billed directly. So slightly more complicated form for DMAS. Apologies, that was kind of unavoidable. We would have had to do a CMS waiver to change that. And again, just the timing really wouldn't have worked out. It would have been slow. It would have slowed things down. So with that, that's kind of the basic process as we're envisioning it. The only other thing maybe to note is it's possible we'll look at changing this if we go into the new fiscal year. We may try to move this payment into the rates. That's kind of TBD. But if this is going to go on for a very long time, it might be simpler to move it into the claiming process. This was kind of our attempt to do this as quickly as possible. I should note, I think Karen Cameron is also on the call. She is our senior advisor in the provider reimbursement division, and is one of the contacts listed in that Word document I mentioned. And she can also help answer any kind of more technical questions you guys might have. So with that, I will stop and answer any questions if I can, and if I can't, I'll be happy to take them back and share them out through your organization.
Well, thank you so much, Thomas. LeadingAge Virginia really appreciates all the collaboration that we've had working with you to develop this process. It looks like we do have a question that has come in. Will this cover all days of stay? Medicaid pays to the first day but not the last day. Will this be the same?
I'll take that back to confirm, but I think the basic is if you can bill for the day to Medicaid, then you could include it in the $20. You would include it in your roster bill. If you're not able to bill Medicaid for it, I don't think you'd be able to include it, but I'll take that back to confirm.
Okay, thank you. Any more questions for Thomas? Okay, well, thank you so much. I know we'll continue to talk and keep our members updated on all the new developments that come regarding this.
Great, thanks so much.
Excuse me. Hi, this is Karen. This is Karen Cameron. I just wanted to add real quickly, we've already started getting some of this data in, and I thought I would add while we're on this call that it's very important to encrypt your data when you send it because it does have PHI in it. and we've gotten several that haven't been encrypted, so we just need to remind everybody to do that. The second thing is that we have confirmed that if you can bill for the day, you would get the additional $20. And of course, this doesn't cover skilled patients, it's just your custodial or intermediate care patients. And then the other thing we've noticed already is on the hospice sheets, when we ask for the name, provider name, and the MPI number, we're asking for the hospice's provider name and MPI number, not for the facility.
Well, thank you. Thank you for that clarification and that additional information. Any other questions before we leave this topic? Melissa, I think some questions have come in for Sarah.
Nope. Not that I see.
Let's see. Okay.
I saw a comment, but not a question.
Okay. Okay, great. Okay. Well, thank you, Thomas, so much for that update. We have a little time left. If we wanted to just use this opportunity to talk about anything that's on your minds or any member discussion about any specific issues. Okay, well, we're here for you. Melissa and I, you can email us directly with any questions, topics that you would like addressed on our next call, which is May 6th at 11. Again, we want to extend our appreciation to the agencies for being on our call today and providing all of these great updates. And we will look forward to speaking with you all again on May 6th at 11 a.m. and just email your questions and reach out to us between now and then. So thanks so much.